可以喂。
现在要吃的吗？我可以把这个放这里吗？
王教授可以开始了，时间到了。
哦，好，OK。呃呃Good, good day, everyone. I'm Dr. Huang Chunyao from Taipei Medical University Hospital, and I think it is very honor for me and to have Dr. Roland as well to conduct these webinar meetings, and which is proposed by the APSC President Jun Li. And I think today's theme is on the acute coronary syndrome. As we know that in addition to the open heart artery theory, early revascularization for acute coronary syndrome manifests as STE and non-STE is another pivotal action fulfilling the time is muscle concept. And today we will have so many experts around Asia to talk about for about the 2025 ACC-AHA, ACEP, and SCAI ACS guide, and we will discuss about the ACS management, the prehospital and primary PCI, and loading of the antiplatelet, as well as beta blocker and anticoagulant and lipid therapies. So there are so many things to talk about today, and we also will talk about the shock status for the MCS and Impella and the VA-ECMO. And before these sections, I would like to have some disclaimer is that the content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of APSC. The views of opinions and expressed in the webinar are those of the faculty members and do not necessarily represent those with APSC. And so make sure that the live streaming content of the webinar will be made available via APSC Cloud and the Facebook and YouTube pages. And okay, let's go and start it. And first of all, I will have Santos to chair the first two speakers, please.
Right. Thank you, Dr. Huang. I'm honored to introduce our first speaker from Indonesia. He is an immediate past president of the Indonesian Heart Association, an interventional cardiologist, critical care cardiologist consultant at the National Cardiovascular Center, Harapan Kita Hospital, Jakarta, Indonesia. Let's all welcome Dr. Isman Firdaus.
Okay, thank you. Good day, Dr.
Good day,
Santos,
doctor.
for chairing this session. So I would like to talk about early pre-hospital activation of PPCI team in STEMI and non-STEMI management. So it is very important, the beginning talk for acute coronary syndrome. Of course, there is disclosure, no disclosure for me. Rapid and coordination, pre-hospital care play a critical role in optimal management of patients with acute coronary syndrome. Pre-hospital is very important, not only in Indonesia, but also, of course, in Asia-Pacific country to prevent the complication of ACS itself, including heart failure, arrhythmia, cardiogenic shock, and other mortality. Acute coronary syndrome including STEMI and non-STEMI. So in the previous concept, STEMI, there is the totally occluded vessel in epicardial, coronary epicardial, and non-STEMI or unstable angina, there is the subendocardial ischemia, or partially occluded in epicardial, coronary epicardial. So both of pathogenesis will be different approach, especially for opening the vessel with the early invasive strategy or conservative strategy. Our data show for STEMI, primary PCI or reperfusion will be reduce the mortality. So it is our report in Harapan Kita Hospital in Jakarta. In all patients STEMI, no reperfusion will increase the mortality almost twice. And that's why the STEMI should send to the PCI capable center to opening the vessel. This STEMI patient, okay, this STEMI patient was the only one who needed immediate reperfusion. Of course, not only STEMI, because 25% of non-STEMI have acute total occlusion. So the concept STEMI in the previous is totally occluded vessel, but there is 25% of non-STEMI also have acute total occlusion. So the reperfusion is also important, not only for ST elevation myocardial infarction, and also for the non-ST elevation. Because there is in STEMI or non-STEMI crisis, 56% of individuals with acutely occluded coronary artery do not exhibit ST elevation. And 25 until 30% of individuals classified as non-STEMI have acutely occluded coronary artery and could benefit for immediate reperfusion. So not only for STEMI for reperfusion, but also non-STEMI. So it is the concept paradigm, the reperfusion from STEMI and non-STEMI. Because ACS are the highest risk for cardiovascular complication acutely, including heart failure and cardiogenic shock in prior to hospital presentation. And rapid, coordinated pre-hospital care, very important to reduce mortality. Also, it is especially for ACS suspicious patient to monitor, to assess the potentially life-threatening event. So the role of emergency medical team for ACES management, including the first medical contact, is very important to early diagnosis, triage, transport and treatment, to have lead ACG pre-hospital, and classify the ACS from information in the first medical contact is ACS or non-ACS, STEMI or non-STEMI, and the role of activated cath lab, primary PCI intervention. First medical contact, vital sign, blood pressure, heart rate, and ECG, transmit, and suspicious of ACS is very important to treat early before patient transmit. If patient ACS with occluded vessel, including STEMI or non-STEMI or very high risk non-STEMI, so the ACG in pre-hospital very important, and contacted the cath lab earlier is very important to bypass time. Primary PCI strategy, of course, as the common strategy to bypass time in emergency department to the cath lab. And in this our data from Indonesia STEMI, primary PCI or reperfusion will reduce the mortality. If no reperfusion, the mortality almost 13 to 15% in hospital mortality. That with reperfusion, the mortality will reduce until 4%. And this is the data that is not only for primary, but also for fibrinolytic treatment. Primary PCI more powerful to reduce mortality than fibrinolytic in Indonesia. The pre-hospital identification of STEMI is very important, early diagnosis. The goal is the treatment, and we hope that the target, the first medical contact to device time, less than 120 minutes or 90 to 120 minutes. Early diagnosis is very important to direct transport to a PCI capable hospital to bypass to the other hospital that are unable or incapable for PCI to lower mortality. So regarding the guideline, it is the class 1 guideline for all community or for region. It is recommended to make the system maintain regional system of STEMI care that coordinate pre-hospital and hospital-based STEMI care process with the goal to reduce the ischemic time and improve survival. So it is including the transport from non-capable or in non-PCI center to PCI center. How to pre-act STEMI to bypass emergency department. So pre-act algorithm is very important to reduce mortality, to activate the cath lab before patient admit to the emergency department. The first, acquiring the pre-hospital ACG transmission, and paramedic interpret this ACS or not, it is occluded high-risk vessel or not, and then if the patient with STEMI and the suitable for STEMI, so the cath lab should be activated earlier before patient admit to the emergency department. So the pre-act algorithm to be applied to patient with ischemic symptom with STEMI, and emergency medical systems should obtain a clean pre-ACG hospital. So the ACG should confirm the ACG show the very high-risk features for STEMI or very high-risk feature for high-risk non-STEMI. So the direct criteria before patient admit to the emergency should be made with the criteria, the ST elevation more than 2 millimeters, the age 30 to 90, pen less than 24 hours, no DNA, and others. It is very important to clean the criteria so the patient exactly need for a perfusion, because false alarm costly and having risk to cause staff fatigue and burnout. So activate the cath lab before PCI is very important for regional or for every area to make the system, emergency medical system for reperfusion. Pre-hospital activation. It is the journal from American Heart Association showed that the pre-hospital activation of cardiac catheterization laboratory for primary PCI was associated with significantly shorter time to reperfusion, achievement of STEMI performance measures, and lower 30 days and 1 year cardiovascular mortality. So pre-hospital activation is a key strategies. Within 10 minutes, and interpret the ACG, clean the criteria, and STEMI suspected in non-PCI facility, and bypassing and go to the PCI capable hospital. So if needed, there is we make the direct consultation to the emergency team or to the primary PCI team and cath lab activation before patient admit to the emergency department or to the cath lab. So it's very important. Activate pre-hospital of cath lab laboratorium before patient admit to the emergency department. So it is meta-analysis. Activation of cath lab before admission will reduce shorter the door to balloon time for patient with suspected STEMI in outside of hospital. And of course, bypassing time reduce door to balloon will increase or will improve survival. Did STEMI patient were the only one who needed immediate reperfusion? Again, it is asking again. Not only STEMI, but non-STEMI have acute total occlusion as benefit for reperfusion to reduce mortality. So pre-hospital management of patients with suspected non-ST elevation ACS in pre-hospital is very important to clean the criteria to direct to the PCI capable hospital. The first from history, ACG, age, risk factors, and troponin. The heart score is very important. We putting the history, ACG is there any elevation and non-specific repolarization disturbance, the age, risk factors. If the score more than 5 or more than 7, so it means it's very high risk to activate the cath lab. So it is the score with, if the heart score is less than 3, so we can rule out. So patient can treat in non-PCI capable hospital. In very high risk features, patient should send to the cath lab less than 2 hours. And then if patient with high risk features, we can perform the invasive strategy with routine invasive strategy electively or in hospital or in patients, including the intermediate risk STEMI. We can routine invasive strategy in hospital or in patients. But in low risk, we can routine and selective invasive strategy. This is the recommendation class 1 for immediate invasive strategy less than 2 hours for patient with non-STEMI with high risk features. So if there is cardiogenic shock, there is the prolonged chest pain, if there is the dynamic ECG changes, so of course we should recommend to immediate invasive strategy less than 2 hours. So it is the study if early invasive strategy based on the symptom onset of non-STEMI. If the symptom onset more than 48 hours, the mortality will be high. Then if we perform the invasive strategy less than 40 or 48 hours. So the shorten the symptom onset of non-STEMI for invasive strategies very important, will reduce the mortality. So the conclusion of my talk is pre-hospital activation play a critical role in the optimal management of ACS patients who need an immediate reperfusion strategy, including STEMI and non-STEMI, very high-risk features. And pre-hospital activation of cardiac catheterization for PCI is associated with a significantly shorter time to reperfusion, achievement of STEMI performance measures, and lower 30 days and 1 year cardiovascular mortality. Using the heart score is very important for invasive strategy and non-STEMI or non-ST elevation acute coronary syndrome. Thank you.
So thank you,
Okay.
Dr. Isman. That was a very, very comprehensive and wonderful discussion of pre-hospital management. So I'd like to ask the audience first, or any of our doctors here, if anyone has questions for Dr. Isman.
Yeah, Santos, and I think Ishman, congratulations for your very fruitful discuss about the pre-hospital sessions. And I'm wondering that that you raise a very good concept about the occlusive and non-occlusive, and instead of ST or non-ST elevations, because it's get us more aware about the pathophysiology of the disease. But what do you think about these new definitions? Although we have the concept, but how do you think that we can really judge the patients with non-STEMI with into the occlusive category and put it directly to the cath lab? Some people say, paper will say that by using the AI algorithms or some methods. How do you think about that in real daily practice?
Yes, of course, in daily practice, whatever device or maybe AI method criteria to determine is occluded or not occluded, in STEMI, almost more than 40% patient is not occluded, but more than less than 40% is occluded. And there is the shifting paradigm in non-STEMI patients, not usually non-occluded, but some of them, 26% is occluded vessel. So to differentiate when a non-STEMI should underwent to the cath lab for reperfusion, of course, it is still challenging. But in my clinical daily practice for early very high risk features, very important. Including the dynamic SAT changes and increasing the high sensitive troponin and using the heart score, we can send to the cath lab. So we can send to the cath lab to see what the vessel is. Is there any occluded or not? But because the 30% patient with non-STEMI, there is the occluded vessel.
Thanks.
Yeah.
So, Dr. Isman, I have a question. I'm wondering how many of your STEMI and NSTEMI patients come into your emergency room with pre-hospital assessment from an emergency medical service? So do they get contacted? Do they have first medical contact most of the time from an EMS outside the hospital, or is the first medical contact usually when they come to the hospital?
Yeah, I work in the private hospital and also in government hospital in National Heart Center. In National Heart Center, every patient sent to our hospital with the ACS, including STEMI or non-STEMI, it should be there is a pre-hospital ECG first. Okay, so they send to our center. So if the patient suitable, this STEMI in the onset is less than 12 hours, so there is no resistance from the family. So we activate the cath lab, so patient will come to our hospital. And of many hospitals in Indonesia, because universal health coverage cover all patients with STEMI with the PCI. So the insurance is no issue in our country. So that's why STEMI and ACS very easy getting the primary PCI or PCI in the hospital.
Yeah, Ismail, I have another question is about the ECG, the equipments. I know that it's very great for you to have the EMT with the ambulance, with the ECG ambulatory. So what's your country's policy for that? In Taiwan, probably we have, although we have the pre-hospital ECG and for many years, and but not until now we start to have some very small reimbursement from the insurance. So what's about your situation right now?
Yeah, the situation right now, so the government starting to build the system. So the name is FAST-STEMI, FAST-STEMI Pharmaco-Invasive Strategy for STEMI. So the government will build the online consultation from the not only from hospital non-capable, but also from the primary care to the directly to the hospital in the top of the primary care. So they send the ECG from the primary care to the hospital with the capable hospital, and the capable hospital will decide, oh, this is STEMI or this very high risk feature for STEMI, send to our hospital. So it is the situation in Indonesia. So if the patient with STEMI or high risk feature for STEMI, so the primary care or the hospital non-capable will send to our center uh, with any kind of transportation. Of course, there is the regionalization. So the nearest hospital. So they will send to the nearest hospital for reperfusions. So this situation in Indonesia and covered by government.
Okay. So thank you, Dr. Ishman. Does anyone else have any other questions? Okay. So if not, we'll move on to our next speaker, who will be discussing emergency medical strategies critical to STEMI and non-ST elevation ACS. He's an attending physician at UB Songdo Hospital, Ulaanbaatar, Mongolia. Let's welcome Dr. Namkhaidor Serengombo. Hello, doctor. Good morning.
Yes, good afternoon, actually.
Oh, yeah,
Here,
good afternoon. Sorry.
time is already afternoon. Can you see my PPT?
Yes.
Okay. Hello, everyone, and dear program director and chairman, dear colleagues. I'm Dr. Namkhaidor from UB Songdo Hospital, Mongolia. I'm very pleased to be speaking with you today, and thank you, organizing committee, giving me this opportunity. We all know that last February, the American College of Cardiology and the American Heart Association just introduced a new acute coronary syndrome guideline. This guideline was a joint guideline with partners such as American College of Emergency Physicians and National Association of EMS Physicians and Society for Angiography and Interventions. We know they have had the last ACS guideline that have been separated by ST elevated MI and as well as non-ST elevated MI. These are already a decade ago. There are still several legacy recommendations with strong database of recommendations, so they didn't update some of them. But recently we had a lot of new clinical trials and new evidence tends to evolve very, very rapidly. So some of the documents are updated. This guideline is really focused on the type 1 MI that is related with the plaque rupture. Today I will talk about the antiplatelet therapy and their loading dose and parenteral anticoagulants and the cholesterol lowering management and for the secondary prevention and beta blockers and oxygen therapy. So my topic is quite big, so I have to talk very quickly, and let's start. In patients with acute coronary syndrome, the initial oral loading dose of aspirin followed by daily low-dose aspirin is recommended to reduce death and MACE. It is recommended by 1A. So, oh, sorry. The 1A, and aspirin has long been considered an integral part of antiplatelet therapy to prevent recurrence atherothrombotic event among patients with acute coronary syndrome, and also reduce the incidence of vascular death after MI. In a secondary prevention trials, it reduces occurrence of vascular and coronary events, including MI and stroke. And after acute coronary syndrome, the aspirin was traditionally considered a lifelong. The strategy of aspirin discontinuation rather than P2Y12 inhibitor discontinuation may now be considered in a maintenance phase after 1 to 3 months in high bleeding risk patients to reduce bleeding risk. And aspirin discontinuation after 1 to 4 weeks after PCI is also appropriate for patients in a full dose anticoagulant in combination with continued use of P2Y2 inhibitors. The loading dose, of course, it's 162 to 325 milligram in patients with acute coronary syndrome without absolute contraindication as soon as possible after diagnosis. The patients who cannot take oral medication, the rectal and IV administration are option for administration, and the maintenance dose is 75 to 100 milligram as before. The clinically available oral P2Y2 inhibitors include the clopidogrel, prasugrel, and ticagrelor. The clopidogrel is the least potent oral P2Y2 inhibitor and requires more time to reach its maximum platelet inhibition after a loading dose because it requires biotransformation in the liver to form active metabolite. Pharmacodynamic variability in response in clopidogrel has been well described, and hyperresponders may be increased risk of MACE and stent thrombosis when treated with clopidogrel after PCI. Ticagrelor and prasugrel are more potent than clopidogrel and achieve more rapid onset on inhibition of platelet activation, but the increased risk of bleeding compared with clopidogrel. Across the spectrum of acute coronary syndrome, addition of P2Y2 inhibitor to aspirin significantly reduces platelet aggregation and has been shown to reduce the incidence of recurrent MACE, but with the increased risk of bleeding. So it is recommended by 1A. The patients with history of stroke and transient ischemic attack, the prasugrel should not be used because of worse clinical outcome. This is a Triton-TIMI 38 trial was the main trial. So the patient with non-ST elevated acute coronary syndrome undergoing PCI, the prasugrel or ticagrelor is recommended to reduce MACE and stent thrombosis. If the patient is managed without planned invasive evaluation, ticagrelor is recommended. When a prasugrel or ticagrelor are unavailable or cannot be tolerated or contraindicated, clopidogrel is still recommended. All these 3 conditions are recommended by 1B. And the patients with non-ST elevated acute coronary syndrome planned for invasive strategy with timing of angiography anticipated to be more than 24 hours. Upstream treatment with clopidogrel, ticagrelor may be considered. For STEMI elevated patients, if do PCI, prasugrel or ticagrelor should be administered to reduce MACE and stent thrombosis. It is recommended by 1B. If the prasugrel or ticagrelor are unavailable or cannot be tolerated or contraindicated, clopidogrel is still recommended by 1C. If the fibrinolytic therapy is going, the clopidogrel should be administered concurrently to reduce death and the MACE. It is recommended by 1A. In acute coronary syndrome, the initial selection of oral P2Y2 inhibitors during the PCI and CABG and non-planned invasive evaluation and fibrinolytic in ST elevated myocardial infarction, it's a little bit all different. So here the dosing concentration, especially for prasugrel, the dose reduction should be considered if the patient is older than 75 or the body weight is less than 60 kilograms. The randomized double-blind STEMI 38 and Plato trials demonstrated that prasugrel or ticagrelor reduced the rate of composite endpoint of cardiovascular death, myocardial infarction, or stroke by 60 to 20% when compared with clopidogrel, as well as reduced risk of stent thrombosis. In a Plato trial, ticagrelor versus clopidogrel include patients with acute coronary syndrome managed with or without planned invasive strategy. Among 28% of the patients who were managed without planned invasive strategy, 15% reduction was observed in the primary endpoint of vascular death and myocardial infarction or stroke with ticagrelor versus clopidogrel. That was highly consistent with 16% reduction in MACE in overall trial. In a randomized double-blind placebo-controlled CURE trial among patients with non-ST elevated acute coronary syndrome receiving aspirin and who were medically managed or underwent revascularization, the administration of clopidogrel significantly reduced the composite of cardiovascular death, myocardial infarction, or stroke. Although prasugrel and ticagrelor further reduced major cardiovascular events compared with clopidogrel in patients with acute coronary syndrome undergoing PCI. So the clopidogrel is an effective alternative P2Y2 inhibitor for use in patients with high bleeding risk and or the contraindication for prasugrel or ticagrelor. In an open-label trial with a high crossover rate among older patients with acute coronary syndrome undergoing PCI, the patients treated with clopidogrel had a similar rate of ischemic events and less bleeding compared with ticagrelor. The management of P2Y12 inhibitors for patients who require CABG surgery, the elective CABG, for the elective CABG, the clopidogrel, prasugrel, ticagrelor interrupt time is a little bit different. So for the clopidogrel is 5 days before surgery, prasugrel is 7 days before surgery, ticagrelor has 3 to 5 days before surgery, and the interruption for at least 24 hours for each medicine. Oral P2Y2 inhibitors should be resumed after surgery when bleeding risk is not excessive, typically 24 to 70 hours. The next topic is intravenous P2Y2 inhibitors. The patients with acute coronary syndrome undergoing PCI who have not received P2Y2 inhibitor, intravenous cangrelor may be reasonable to reduce peri-procedural ischemic event. This is reproduced from the 2021 ACC CHAA guideline for coronary artery revascularization. The transition from the IV cangrelor infusion to oral P2Y2 inhibitor, the 3 medicine loading doses same before, and it can be immediately after discontinuation, we can begin all these medicines. intravenous glucoprotein 2B3A inhibitors, the patients undergoing PCI with large thrombus burden, and during the PCI, the no reflow and the slow flow, adjunctive use of intravenous or intracoronary glycoprotein 2B3A inhibitor is reasonable to improve procedural success and reduce infarct size. This is recommended by the 2A. And these drugs should not be administered routinely due to lack of ischemic benefit and increased risk of bleeding just during the thrombus burden. Parenteral anticoagulation. So in non-ST elevated acute coronary syndrome, the upstream anticoagulant therapy is recommended. So intravenous unfractionated heparin is always the first choice to useful to reduce ischemic events. And if it's not anticipated, either enoxaparin or fondaparinux is recommended, alternative to unfractionated heparin to reduce ischemic events. If the patient is undergoing coronary revascularization, the parenteral anticoagulation should be continued until the revascularization cabbage or PCI to reduce the ischemic events. In acute coronary syndrome patients undergoing PCI, the unfractionated heparin is useful to reduce ischemic events, and B-valirubin is also useful alternative to unfractionated heparin. And non-ST elevated acute coronary syndrome patients undergoing PCI, B-valirubin may be reasonable as an alternative to unfractionated heparin to reduce bleeding. The patients with acute coronary syndrome, intravenous enoxaparin may be considered as an alternative to unfractionated heparin at the time of PCI to reduce ischemic events. And the fondaparinux should not be used to support PCI. Fondaparinux has a high risk of catheter thrombosis. And ST elevated myocardial infarction patients treated with fibrinolytic therapy, the parenteral anticoagulation should be continued for duration of the hospital stay. So this means maximum of 8 days, and until revascularization is performed, it can be reduced ischemic events. It is recommended by 1A. And the patients with ST elevated myocardial infarction treated with fibrinolytic therapy who are not intended to undergo the invasive approach, enoxaparin is recommended to reduce ischemic events. And patients treated with fibrinolytic therapy who are not intended to undergo invasive approach, fondaparinux is also one of the choice to reduce ischemic events. This is recommended by also the 1B. The dosing of the parenteral anticoagulation in acute coronary syndrome. For the unfractionated heparin, we all know that 60 international units per kilogram, and we need to check the APTT from 60 to 80 seconds. This is the main thing. And if the patient has already prior anticoagulant therapy, we use unfractionated heparin, and we need to check ACT, and we need to achieve it ACT to 250 to 300 seconds. With the fibrinolytic therapy, the loading dose is 60 international units per kilogram, and maximum we can use it 4,000 international units. And B-valirudin, we have exact amount of the dose. To support PCI, we need to use it 0.75 milligram per kilogram bolus and 1.75 milligram per hour IV infusion during the PCI procedure. Enoxaparin, we use it 1 milligram kilograms subcutaneous every 12 hours. But with the patient creatinine clearance is less than 30, we reduce dose to 1 milligram per kilogram per day subcutaneous. With the fibrinolytic therapy, if the age is less than 75 years and 30 milligram IV is bolus and followed in 15 minutes by the 1 milligram kilogram subcutaneous every 12 hours. If the age is over 75, we don't need to bolus and just keep it in 0.75 milligram per kilogram, 0.75 milligram per kilogram subcutaneous every 12 hours. In fondaparinux, we can use it also, but we shouldn't use it to support PCI because of high risk of catheter thrombosis. The next big topic is the lipid management, and in patients with acute coronary syndrome, the high-intensity statin therapy is always recommended to reduce the risk of MACE. It is recommended by 1A. And also, if the patient is already on maximally tolerated statin therapy with LDL cholesterol is still higher than 70 milligram per deciliter, we need to add non-statin lipid-lowering agents to recommend to further reduce the risk of MACE. If the patient is not tolerated in statin, we can use non-statin lipid-lowering therapy is recommended by 1B to lower LDL cholesterol to reduce risk of MACE. And some patients with acute coronary syndrome who are already on maximally tolerated statin therapy with LDL cholesterol is 55 to 69 milligram per deciliter, and adding the non-statin lipid-lowering agent is reasonable to reduce risk of MACE. It is recommended by 2A. And concurrent initiation of ezetimibe with acute coronary syndrome patient in combination with maximally tolerated statin may be considered to reduce the risk of MACE. It is recommended by 2B. So the patients who are not on a statin, we just start the low and moderate intensity regime. If the initiation is successful, and maybe we can initiate the high intensity statin therapy and may consider concurrent adding the ezetimibe. And if the patient is already maximally tolerated statin regime, and we check the LDL cholesterol level, and if it's lower than 55, we continue. And if it's 55 to 69, we have to consider some non-statin LDL lowering therapy is reasonable. It is recommended by 2A. If the LDL is not in a goal, it means LDL is higher than 70 milligram per deciliter, we have to add the non-statin lowering therapy by class 1. The patient is intolerant or refusal because sometimes statin therapy has some patients are not tolerated on the muscle pain or something on the liver function, or so we need to add the non-statin LDL lowering therapy directly by class 1. And non-statin treatment options for the lowering LDL cholesterol patients is we have ezetimibe and some monoclonal antibodies, evolocumab, alirocumab, and the PCSK9 inhibitor, inclisiran, and bempedoic acid. And they all can reduce the LDL by 15 to the maximum 60%. So some of the studies are ongoing, so some outcomes are not yet. So but still we know that they have some potential adverse effects. For example, the injection site reaction and hyperuricemia, sometimes the gout, gallstones, and liver function abnormalities. And the recommendation for the beta blockers, all patients with acute coronary syndrome without contraindication, early initiation of oral beta blockers are recommended to reduce reinfarction and ventricular arrhythmia. So it is recommended by 1A. And renin-angiotensin-aldosterone system inhibitors also recommended by 1A, but the patient must be in a high-risk patient and left ventricular ejection fraction lower than 40, or patients with hypertension, diabetes, or ST elevated myocardial infarction with anterior location. These are the indication for using the ACE inhibitors and ARBs and angiotensin receptor blockers. They can reduce the all-cause death and the MACE. And also the mineralocorticoid receptor antagonists are indicated to reduce all-cause death and MACE. For patients, ejection fraction is lower than 40. This is recommended by 1B. The patients with acute coronary syndrome who are not considered in high risk, the oral ACE inhibitor and ARBs are reasonable to reduce MACE. It's a 2A recommendation. The oxygen therapy, all patients with acute coronary syndrome confirmed if the patient is hypoxia, the oxygen saturation is less than 90. The supplemental oxygen is oxygen to increase oxygen saturation to greater than 90 is recommended to improve myocardial oxygen supply and decrease the anginal symptom. If the patient saturation is greater than 90%, the routine administration of supplemental oxygen is not recommended because of it doesn't improve the cardiovascular outcome. There are two trials, AVOID and DETA2X-MI. So according to these trials, we still we can understand that the oxygen supply is, if it's lower than 90, it's we need to give oxygen, but they have these studies were unable to define the optimal oxygen saturation target range to minimize the potential harm and maximize the clinical benefit. They observed a relationship between the oxygenation and the outcomes appeared to be U-shaped, with the lowest mortality rate described for those patients with an oxygen saturation 94 to 96 at the presentation. The analgesic treatment for the cardiac chest pain, of course, the nitroglycerin, we should give sublingual or the IV, and the morphine and the fentanyl. But giving all this medication, considered for persistent anginal pain after the oral nitrate therapy, and then we have to check the systolic blood pressure. The systolic blood pressure is lower than 90. It must be, it can be a contraindication, and we have to avoid if there's inferior wall infarction. The morphine is used for relief of pain, but it can delay the effect of oral P2Y2 inhibitors absorption. So if it's possible, we have to avoid it and monitor closely for the adverse effects. And that's all, I think. It's time.
Thank you, Dr. Namkai, for that very comprehensive discussion on medical therapies for STEMI and non-ST elevation ACS. Does anyone in our audience have questions? Dr. Huang, do you have any questions or for Dr. Namkai?
Yeah. I have one question is that about thank you for introducing us about the current guidelines but you know that for different areas we have different preferred for every kind of drugs use. For example, the antiplatelet agents as for I have a question for the using of the dosage, because currently the ESC guidelines suggests as like in the ACS settings, we should not pretreat the P2Y12 in advance before we get the angiograms. So you know that in previously we are asked to preload the dual antiplatelet in the ER, and we send patient to the cath lab and do the PCI. And but currently they suggest more favor on clopidogrel and prasugrel. I think probably because of the hemodynamics and clinical trial data, the starting evidence is showing that probably not to preload is better. So what about the situations in Mongolia? Do you still started to follow this rule or as usual before? Thanks.
Thank you for your question. And I think then every country has some issues about the medical situation. In our country, some medicines are not available. For example, prasugrel is not available in our country. So there are two main things discussed. One is during the hospital management, and the second is after discharge, the duration of the antiplatelet therapy. And one issue is also the loading dose, as you mentioned. So I think in our country, some the medicines are because of unavailable. We just use the clopidogrel or ticagrelor a lot. And before PCI, we always use the loading dose as written in a guideline. So it can be, but I think the benefit is it can, of course, the data showed it has the good outcome than the without loading dose. But for the Asian people, what do you think? Is it always use the American or European guideline? What do you think? What's your opinion?
Yes, I agree with you that because like in Taiwan, we have all three, but we have the clopidogrel and also the reduced dose, the prasugrel. You know that the Japanese dose have the 3.75, and the Taiwan, we follow this. But I think this is only two areas in the world to follow this dosage. But it also means that it's not a potent dosing. It's probably the platelet inhibition rate is the same as the clopidogrel, and the other one is the ticagrelor. I think a much potent P2Y12. I think that the ESC suggests that the not to pretreat is that because of the previous bleeding tendency for the prasugrel standard dose. And also, I think ticagrelor had the potential to not to pretreat because of the the pharmacodynamics of the very easily quick search of the drug concentration inside the serum. So probably it will be feasible. But when considering about the clopidogrel, I'm not so sure. I think this is from my personal experience, and I think the clopidogrel, for the serum concentration to go to a certain degree is not so quick. So probably the not to preload, I'm not so sure it is a good idea or not. This is what I think. Thank you.
Thank you.
All right. So I think it's the same thing in here in the Philippines. We don't have prasugrel available. We only have your standard aspirin, your clopidogrel, and then your ticagrelor. At least from my experience, in patients presenting with ST elevation MI, we do use aspirin and ticagrelor more. But I have noticed that in other secondary and smaller hospitals who are not PCI capable, they still use clopidogrel as a theta Y12 loading instead of using ticagrelor, even if they have plans to transfer the patient to a more PCI capable hospital. At least that's here in the country.
Well, my opinion is if we use the more potent antiplatelet therapy, of course, the bleeding risk is also increasing. So sometimes if it's more potent, maybe we can evaluate the patient. The precision medicine is now very hot in the recent years. So maybe we can reduce the GI bleeding by aiding the PPIs. And of course, we can use some de-escalation strategies. And if all the medicines are available, we are happy.
I have a question for the doctors here, especially for Dr. Namkai or Dr. Huang. Do you, for example, if you do get patients who present with non-ST elevation MI who have a high likelihood of having multivessel disease, in the emergency room, do you immediately load both the aspirin and the P2Y12, or do you wait for the angiogram, or load the aspirin first, go bring down the patient to the cath lab, do the angiogram, and then depending on the results of the angiogram, load the P2Y12? So how is it in your daily practice?
In our hospital, we use the loading dose directly.
Yeah, in ours, we also use the preload. Because it's still a percentage, like 30% use the clopidogrel and with the aspirin. So we suggest that. But for the setting of the ticagrelor, I'm not so sure. But you know, in daily practice, sometimes very time-consuming or very, I think,
Yes.
not so friendly for some physicians, saying that they have to care about the patient. They also care about the medications they have to prescribe in the angio room. So probably they also preferred for the preload, the settings. Thank you.
So if there are no other questions, we shall move on to our next speaker. So Dr. Huang, I give you the honor of introducing our next speaker.
Yeah, thank you, Santos, and this is my honor to introduce to all of you the third speakers from Thailand, Dr. Lee Chicharong, and the assistant professor and the interventional cardiologist in the cardiology unit of the Department of Internal Medicine, Faculty of Medicine, Prince of Songkhla University, the Songkhla, Thailand. And his topic to deliver us today is the emergent PPCI strategy with or without preceded fibrinolysis in ST elevation and MI management. And the other point is on the IRA only or complete revascularization in multivessel STEMI. Doctor, please.
Okay, thank you very much for a kind introduction, and good morning or good afternoon. Now it's really late in Thailand, in the morning. So, and thank you for having me today. So my task today is about infarct-related artery only or completely vascularization in multivessel STEMI patient. So about half of the STEMI patient had a significant lesion in non-carpet artery. And after we treat carpet lesion successfully, there are potentially problems with this lesion in the non-carpet artery. It may cause a recurrent MI in the future, leading to death, or it may cause progressive worsening of the symptom that may require further intervention, maybe unplanned intervention. So three questions are important when dealing with STEMI with multivessel disease. The first important one is that, is non-carpet lesion intervention beneficial, or should we await symptom recurrence before we proceed to the subsequent intervention? If there is a benefit of non-carpet lesion revascularization, The second question is that how should we determine which lesion require revascularization? This is problem about the guidance strategy. Should we use angio or should we use FFR to guide the PCI? The third one is the optimal timing. Should we perform non-corporate lesion intervention immediately at the time of index primary PCI, even patient came in the morning 2 a.m., or can we wait a little while, maybe during the index admission 2 or 3 days later, or after discharge? This slide shows the outline of my talk. So this is evidence that we have when we deal with the STEMI patient with multivessel disease. In the patient with cardiogenic shock, we have carpet shock. And you can see that many studies asking the question, what about complete revascularization in hemodynamically stable after successful PCI of the carpet artery? You can see that some study use angiographic guided and some study use FFR guided. And one study, a fire study, use physiologic guided, either by FFR, IFR, or QFR. And we have two dedicated studies that compare FFR versus angiographic guided, the flower AMI and the frame AMI. About the optimal timing, we have evidence from the multi-star AMI and BioVas. And I will finish my talk with the recommendation from the ACHA 2025 guideline for ACS. Looking back in 2013, when the primary study was published in the New England Journal of Medicine, this study compared angiographic guided complete revas versus carpet only PCI in STEMI patients. You can see that the angiographic guided complete revas resulted in the lower risk of cardiac death, MI, or refractory angina. And the difference was mainly driven by the difference in the rate of myocardial infarction, which is lower in the angiographic guided complete revas. The COPRIT study, which reported the long-term follow-up about almost 6 years, showed that the angiographic guided complete revas resulted in the lower risk of death, MI, heart failure, or ischemic-driven revascularization when compared to the COPRIT-only PCI. The complete study, which is a large-scale study in this topic, comparing complete versus carpet lesion only revascularization in hemodynamically stable STEMI after successful carpet lesion PCI. The timing of complete revascularization in this study is the index during the index admission in 2/3 of the patient or after discharge in 1/3 of the patient. And majority of the patients achieve complete revascularization, mainly by angiographic guidance. The primary endpoint of the study showed that the complete revas strategy reduced the risk of cardiovascular death or new myocardial infarction when compared with the carpet lesion only PCI, with the number needed to treat of 37. Looking into the individual component, you can see that the difference was mainly driven by the lower risk of myocardial infarction and ischemic-driven revascularization in the complete revascularization arm, without significant difference in the rate of all-cause or cardiovascular mortality between the two arms. So we have seen from the study that used the angiographic guided PCI and demonstrate the benefit of complete revascularization. And what about the FFR guided? We all know that in the stable patient, FFR is helpful for interventionists to determine which lesion should be treated, which lesion we can safely defer, and what about the FFR guided in STEMI with multivessel disease? The NADAMI-3 prime multi and compare acute, compare FFR guided complete revas versus carpet lesion only PCI. The timing of the complete revas in the NADAMI-3 pre-multi was during the index hospitalization with the mean of 2 days. In the compare acute trial, it was performed immediately during the primary PCI in 80% of the patient. You can see that both studies show that with FFR guided PCI in non-carpet lesion, it can reduce the risk of primary outcome, the death, MI, revascularization, plus or minus stroke in both studies. Looking into the individual endpoint, you can see that the difference was mainly driven by the lower risk of repeat revascularization in the FFR guided complete revascularization arm without any difference in the rate of death or myocardial infarction. Recently, the FIRE study that enrolled the elderly patient with acute coronary syndrome, and you can see that 1/3 of the patient in this study presented with STEMI. And this study compared physiology-guided complete revasc versus complete lesion-only revasc in elderly. You can see that the modality of physiology assessment can be FFR or QFR or IFR in this study. And this study showed that with the physiology-guided complete revasc, it can result in the lower risk of death, MI, stroke, or revascularization when compared to the complete lesion-only intervention. Looking into the individual endpoint, you can see that with the physiology-guided complete revasc, it can reduce the risk of death, MI, and repeat revascularization, which is a hard endpoint, right? Or cause death and MI reduction. About the interaction with the presentation, there was no significant interaction between STEMI or non-STEMI presentation and the primary outcome. So it may apply to the STEMI patient as well. So now we have seen that there is a benefit of complete revascularization in STEMI with multivessel disease, either with angiographic guided or FFR guided. The second question is that how to determine which lesion require revascularization. This is about the guidance strategy. So we have an option of angiographic guidance, which is simple and readily available. The con is that maybe we may treat non-flow limiting lesion. With the functional assessment, we have FFR, IFR, which is a pressure-wide assessment, and we have now angio-based FR, which is a required no pressure-wide. And this concept rely on the benefit when using the functional assessment is that we can identify flow limiting lesion and we treat that lesion, or maybe we can identify non-flow limiting lesion and we can safely defer PCI for that lesion. And this may require inferior stent implantation, reduce the total stent length, which means that maybe we can reduce the stent-related event later on. But the caveat of using functional assessment is that it's a little bit more challenging in STEMI setting, right? The patient may not tolerate the long procedure, especially when we perform the non-carpet lesion assessment during the index primary PCI. Another issue is the instability of microvascular function that may result in the problem with non-carpet lesion severity assessment. You can see that FFR may underestimate the severity of non-carpet lesion. IFR may overestimate the non-carpet lesion severity. One study report that the FFR value can decrease in about 0.03 value when compared between index primary PCI FFR and the 30-day FFR later on. And IFR can range from 0.01 to 0.03. For the angio-based FR, there is evidence showing some mismatch with the pressure-wide based assessment, and angio-based FR may underestimate the severity of non-carpet lesion as well, similar to the FFR. Another important point is that many patients with STEMI and multivessel disease, they have a lesion in a non-carpet vessel that harbor vulnerable plaque. It means that this lesion may cause MI in the future, even the lesion may not cause a flow limitation. This is a sub-study of OCT in non-carpet or non-infarct related artery in the complete study in about 100 patients. They report that about half of the patients had a thin cap fibroateroma, which is a vulnerable plaque in the obstructive lesion. Another 20% of the patients had thin cap fibroateroma in the non-obstructive lesion, and 1/3 of the patient had non-thin cap, maybe thick cap or less vulnerable plaque in the non-carpet lesion. So this lesion may be identified by the FFR as a non-flow limiting lesion, and maybe we defer PCI for this lesion according to the FMR value. And this lesion may or may not cause MI or repeat revasc in the future. This is one of the caveats for the functional assessment of the non-carpet lesion. About the dedicated study that compare FFR versus angiographic guided PCI in STEMI is the Flower MI. You can see that in this study, the FFR guided PCI was not significantly different from the angio guided PCI in terms of the all-cause death, MI, or urgent revascularization at 1 year. You can see that the rate of the composite event was numerically higher in the FFR-guided PCI at 1 year, and there was no significant difference in terms of non-fatal MI or hospitalization for recurrent ischemia between FFR and angiographic-guided PCI. In contrast, the FRAME AMI study, which enrolled smaller patients compared to the FAVR MI, they demonstrate that FFR-guided PCI resulted in the lower risk of all-cause death, MI, repeat revasc when compared to the angio-guided PCI at the follow-up of 4 years. Looking into the individual endpoint, you can see that in the FRAME AMI study, they can demonstrate that FFR-guided resulted in the lower risk of hard endpoint, such as all-cause mortality, cardiac death, or all types of MI when compared to the angio-guided strategy. The full rewasc study, which published last year in the New England Journal, in my opinion, it adds more uncertainties about FFR-guided strategy in STEMI with multivessel disease, because you can see that this study compare FFR-guided complete rewasc versus culprit lesion only PCI, and 80% of the patients received stage procedure with FFR guidance in the active control arm, active arm during the index hospitalization with a median of 2 days. This trial demonstrated that there was no significant difference between the two groups in the rate of composite cardiac event. And there was no significant difference in terms of cardiac death, MI, or unplanned revascularization between FFR-guided and culprit-only PCI group. But one of the interesting points is that this study demonstrates that with the FFR-guided complete revasc, there was a significant increase in the risk of any-stent thrombosis and also any restenosis in this group of the patient compared to the culprit lesion only. In my opinion, I think one of the key messages from this study is that when we need to do a PCI in the non-culprit vessel, we need to do it very good with a high-quality PCI, maybe with intravascular imaging guidance, also to reduce the risk of stent-related adverse event at the long term. The last question is about optimal timing of complete revascularization, either immediately or staged, before or after discharge. The pro of immediate revascularization is that we can provide the immediate protection from non-culprit related events such as MI, and it's only single cath lab visit. It may reduce total hospital stay. The con is that it requires longer procedure time. Maybe patient may not tolerate procedure well, and also interventionists and also the team when we need to do it early in the morning. And this may require more contrast use, and also the problem with vasoconstriction may prevent accurate assessment of the non-culprit lesion severity. For the stage procedure, the pro is that patient is more stable, we have more time, and it's may better to get the lesion assessment in the stable condition, and we have more time for renal protection, especially in CKD patient. The con is that the risk of non-culprit lesion-related event increasing as the times go by, especially if we wait for a long time before we bring patient back to the cath lab to get the procedure done. We have the evidence from the multi-star AMI and BioVasc that compare immediate versus stage PCI. And the timing of stage PCI in this study majorly after the index procedure, after the discharge from the index MI, but within the 6 weeks. Multi-star MI showed that immediate complete revasc reduced the risk of all-cause death, MI stroke, unplanned revasc, and heart failure hospitalization compared to stage PCI later on. And the BioVasc showed that the immediate complete revascularization was non-inferior to the stage PCI. And both studies showed that with the immediate complete revasc, it can reduce the risk of MI and also the unplanned revascularization in both studies. When we have many options in one condition, the one way to get the answer is to use the evidence from the network meta-analysis that allow indirect and direct comparison between each strategy. And this is a network meta-analysis published in Eurointervention this year. It showed that complete revascularization, especially if it was done during the index PCI, the primary PCI, It can reduce the risk of cardiac death, NMI, compared to the infarct-related artery-only strategy. With the use of network meta-analysis, we can get the probability of the best treatment with these 5 strategies, and you can see that with angiography guided immediate CR, the probability of this option to be the best treatment is 82%. And as well as the functional guided immediate completely was, the probability of this option to be the best treatment is 83%. So from this network meta-analysis, it's quite clear that complete revascularization reduce the adverse outcome either with the angio or FFR guided, but we should consider this procedure to be done immediately or not so late. About the STEMI patient with cardiac shock, we have cardiac shock that demonstrate that multivessel PCI at the time of the index PCI increase the risk of death or renal replacement therapy at 30 days, and there was no significant difference in terms of interaction between non-STEMI STEMI for the outcome of the procedure. So the guideline recommend against the routine use of the PCI of the non-infarct related artery at the time of primary PCI in patients with cardiogenic shock with acute MI. So the ACC/AHA guideline gave class 1 recommendation for PCI of the non-culprit artery vessel in hemodynamically stable patient with STEMI and multivessel disease after successful PCI of infarct-related artery. And they gave a class 2B recommendation for multivessel PCI at the time of primary PCI, which is preferred over stage procedure later on, especially in the low complex multivessel disease not intended for CABG. And they gave class 2A recommendation for elective CABG for patients with multivessel disease who has significant lesion in non-infarct related artery involving LAD or left main, especially in the patient with complex multivessel disease. So my conclusion for this talk is that in hemodynamically stable STEMI after successful primary PCI of infarct-related artery, complete revascularization improves outcomes. Immediate complete revascularization may reduce recurrent ischemic events, but I think that stage PCI within index admission maybe 2 or 3 days later on, maybe a reasonable option considering the cath lab congestion and also burden for the team and for the interventionist. There are uncertainties regarding the base guidance strategy, but we can see from the network meta-analysis, NGO or FFR guided have a high probability to be the best treatment option. And we have ongoing trial that may shed the light in this matter, the STEMI and complete 2 times, which compare FFR versus angio guided complete revasc, and also the I-model study that compare IFR versus MRI guided complete revasc in STEMI. Thank you very much for your attention.
Thank you, Dr. Chicharan, for a very, very comprehensive review about the current evidences concerning about how do we treat for patients with multivessel disease in acute coronary syndromes. I think you raised so many evidences showing that the more benefits for the earlier and even the same times interventions, but with the exception of the patient with cardiogenic shock. And so I'm wondering, is there any comments or questions from our speakers or panelists? Yeah, Roland.
Yes. So Dr. Chicharian, I'm curious for your own practice. If you have a patient who presented with STEMI and you do need to do revascularization of a non-culprit artery, do you personally wait a few days and do the stage procedure to hopefully let the inflammation, let the microvascular dysfunction settle before doing it? And do you do both physiology and either IVUS or OCT before doing the non-culprit arteries?
Thank you very much for that question. It's a very important question. So in my practice, I rarely perform a multivessel PCI at the time of index PCI. I had a not so good experience with 2 or 3 cases because we need to consider in the context of our country, patient may present very late, maybe 7 or 8 hours after the onset of the symptom. And when we successfully open the artery, maybe there is a stunning of the myocardium. And when we perform the in that case, when we perform the non-cooperative lesion PCI, the slow fall occur and then the patient crash. But we fortunately we can manage to get the patient survive from the index hospital. So I think that the evidence show that immediate complete revasc is maybe potentially benefit for the patient, but in real life practice, we need to consider many things, right? Because as I mentioned, if the case came 2 a.m. in the morning and we have already done 2 or 3 primary PCI procedure, the team is very exhausted. I don't think it's a good idea to add the time for the non-cooperative lesion at that time, but maybe it's reasonable to bring patient back 2 or 3 days later on, especially if patient had a really severe stenosis of the non-cooperative lesion, right? Because if we wait for 1 or 2 months, maybe 3 months, patient may come back earlier because of the recurrent MI of the non-cooperative lesion. For the guiding strategy, I think that it's fine to use angiography or FR. I use both strategy, but for the FR, I usually use it or maybe other option for physiologic assessment in the non-cooperative lesion that
some interrupt.
lesion that maybe more than 60% stenosis by Q.
I think Dr. Ply is having a bad signal.
Okay. It seems there's some transmission problems, but I think that for each occasions, I think whether or not to treat it at the same time ad hoc or with the stage should depends on the patient's situations, vulnerabilities, and also the team's capabilities to do that. And but I think so far to do it earlier, to treat the lesion earlier, and it should be the best practice right now, I think. So okay, and is there any questions about this issue? Okay, but I'm not so sure is the next one is Dr. Liu or Rollins. Okay, great. And the other, this is also my privilege to introduce our also our chair and also our speakers, Professor Roland Santos from Philippines, and he's currently the work in the internal medicine, adult cardiology and interventional cardiology, St. Luke's Medical Center. Quezon City, Philippines. And today the talk is about the choice of timing or emergency reperfusion strategy in non-STE-ACS management for very high risk or intermediate risk and versus low risk group. Dr. Roland, please.
All right. Thank you, Dr. Huang. Thank you for the introductions. I'd like to share my slides first. I hope you can see it. All right, so good morning, everyone. I'd like to thank the APSC for giving me the opportunity to present, and thank you for good afternoon to everyone joining us today. So my part would be to discuss the choice and time of emergency reperfusion strategy in non-ST elevation acute coronary syndrome for very high risk, intermediate, and low risk groups, which is in alignment with the recently published 2025 ACC/AHA guidelines on acute coronary syndromes. So to start the segment off, let me preface this by saying that we all know that acute coronary syndromes present with either ST elevation or non-ST elevation myocardial infarction. Now, in most cases, STEMI patients almost always present with an acute occlusion of a culprit artery where immediate reperfusion is necessary. Now, on the other hand, your non-ST elevation MI, with a few exceptions, like was mentioned earlier, wherein a percentage might still present with acute occlusion, but a large population of these patients is composed of more heterogeneous population with different etiologies, such as your plaque disruption, supply-demand mismatch, coronary vasospasm, thrombus formation, dissection, microvascular dysfunction. As such, the proper timing for invasive strategy and reperfusion for these cases are very variable and based on multiple factors. Now, current systems of care and current guidelines decide to produce the time for primary PCI for patients with STEMI have been well established and been consequential to reducing the risk of early death. Now, the timing of reperfusion in STEMI with the current guidelines is that the first medical contact to the device activation should be less than 90 minutes, less than or equal to 90 minutes for primary PCI capable hospital and less than or equal to 120 minutes in patients requiring hospital transfers. Now, we've used this 90 to 120 minute time frame as a performance metric for the primary PCI for STEMI. However, in contrast to STEMI patients, the optimal timing for invasive coronary angiography and revascularization for NSTEMI is still controversial and debatable, with evidence that high-risk patients and very high-risk patients would benefit from an early invasive strategy. So the current 2025 guidelines have highlighted current routine and invasive versus selective invasive strategies for NSTEMI, as well as the timing for coronary angiography for those in whom an invasive approach is planned. So we see here that we do have in patients with non-ST elevation acute coronary syndrome who are at intermediate or high risk of ischemic events with intermediate to high risk features, an invasive approach or an immediate invasive approach with intent to proceed with revascularization is recommended. In contrast, with patients who are at low risk for ischemic events, either a routine, meaning an immediate invasive approach, or a selective invasive approach is recommended for these patients who may require revascularization to reduce major adverse cardiovascular events. And usually these patients require further non-invasive risk stratification prior to even considering coronary angiography, because these patients who are at low risk derive less benefit from a routine invasive approach. But these recommendations for either routine invasive versus selective invasive strategy all have a class 1A recommendation from the current guidelines. Now, these recommendations are based from collaborative meta-analysis of certain RCTs, wherein they found out that the routine invasive approach reduced death or MI by 18% when compared with the selective invasive approach. Now, other meta-analyses do have some certain type of conflict with that, in that low-risk patients have less benefit from routine invasive approach, particularly those with normal cardiac biomarkers. So in general, they do suggest that low-risk patients should go non-invasive stress testing or coronary CTA first prior to hospital discharge to determine the need for coronary angiography, while patients with recurrent angina or ischemic symptoms while admitted should be considered for coronary angiography on admission. So now we have these two groups of patients. You have your high or intermediate risk and low intermediate risk patients who have been diagnosed with non-ST elevation MI. Now, for higher intermediate risk, based on the recommendations, we do have a class 1 indication for immediate routine invasive strategy or angiography with an intention of revascularization. Now, depending on the results, you do a PCI or a CABG or for patients who have unremarkable angiographies, we can do medical therapy or consider additional diagnostic workups such as your cardiac MRI, your IVUS, your OCT, consider your FFR, IMR, or CFR as a workup for certain conditions such as your MINOCA. Now, for lower risk NSTEMI acute coronary syndromes, you have two choices. You either do an immediate routine invasive strategy or a selective invasive strategy. Now, if you do a selective invasive strategy, a preference for non-invasive testing should be done first, meaning if you do plan on doing angiography to a patient with a low risk NSTEMI, you do stress testing first or CCTA or those with recurrent symptoms. If that turns out positive, you can proceed with your routine strategy of coronary angiography. But if that turns out negative, you can opt to do medical therapy alone unless the patient has recurrent ischemic symptoms. So now that we've established that we can use either routine or selective invasive coronary angiography for patients with NSTEMI depending on the risk stratification, what then about the timing? How quickly should we do the angiography or an invasive strategy for these patients? Now, in general, for patients who are very high risk or are hemodynamically unstable, those with refractory angina, those with hemodynamic instability, the need for immediate revascularization gets a class 1 indication. So we need to do the angiography immediately. However, for patients who are at high risk or intermediate risk of events, it is reasonable to choose an early invasive strategy within 24 hours. And for those who are not high risk, those are low to intermediate risk, it is reasonable to perform the angiography before hospital discharge. However, both these two have a lower recommendation compared to those who are hemodynamically unstable or those who are very, very high-risk patients. So here we have our stratification for patients with non-ST elevation ACS that will guide us on the treatment strategy that we will do. Again, for unstable or very high-risk patients, those in shock, those with symptoms of heart failure, pulmonary edema, hemodynamic or electrical instability, an immediate invasive strategy has a class 1 indication, meaning we do an angiography less than 2 hours. Now, for high-risk patients, those with Gray score more than 140, a very high troponin I, dynamic ST segment changes, routine invasive strategy is still a class 1 indication by doing coronary angiography less than 24 hours upon admission. And for intermediate risk and lower risk NSTEMI ACS, anyone with Gray risk score from 109 to 140, absence of symptoms, or downtrending troponin values, we can still do a routine invasive strategy. However, coronary angiogram may be done before hospital discharge, usually less than 72 hours after the index event. Now, for low risk NSTEMI, we do recommend doing routine invasive or selective invasive by doing non-invasive risk stratification first during hospitalization and then go for coronary angiography before the discharge if the non-invasive testing turns out positive. So this is how we could be guided in the treatment strategy for patients depending on the risk stratification. It's very important to use your scoring systems such as your TIMI or Gray risk scoring systems, as well as your ECG and your cardiac biomarkers in order for us to stratify the patient properly. But as you can see, regardless of the risk of the patient, an invasive strategy, either routine or immediate or even selective, is still a class 1 indication. Now, there's a lower recommendation for patients with high risk, intermediate risk, and low risk for immediate coronary angiography and can usually be delayed either less than 24 hours or even before the discharge of the patient. Now, these recommendations have been established based on certain studies, particularly your TMAPS, your timing of intervention in acute coronary syndrome, where patients who presented with NSTEMI, they check if either early intervention less than 24 hours or delayed intervention more than 36 hours would improve your composite of death, MI, stroke. And they did find out that it does not result in a decrease in composite death of MI, stroke at 6 months compared to delayed intervention for patients with NSTEMI, except for patients who are high risk or those for patients with gray score more than 140%. Now, another study, your verdict study, also studied the role of performing invasive coronary angiography within 12 hours of diagnosis or within 48 to 72 hours. And they found out that there's no significant difference between the outcome of all-cause mortality, non-fatal MI, hospital admission for refractory ischemia or heart failure between the very early and the deferred invasive strategy. However, they did find out again that in patients with a gray score more than 140, indicating higher risk, the very invasive strategy, less than 12 hours, showed improved outcomes compared to the deferred approach. So, what does this tell us? At the very least, there's a trend towards benefit for patients with high risk NSTEMI ACS with grace risk score greater than 140, aged more than 75 years, diabetes, and elevated cardiac markers. These patients would favor and would benefit from an earlier invasive approach. However, for low to intermediate risk non-ST elevation acute coronary syndrome, the timing does not appear to be critical, and that delayed strategy does not appear to increase future risk of MACE. In fact, certain randomized data have demonstrated an overall no significant difference in death or MI between an earlier versus delayed invasive approach in patients with very low risk NSTEMI. So now that we have the risk stratification for this, we can carefully stratify our patients as to very high risk, intermediate, and low risk, and give the proper recommendation as to the timing of an invasive strategy. Now that we know that we can either do an immediate, a routine, or an even selective and invasive strategy, what then should be the revascularization of choice? Now, most patients with NSTEMI do present with multivessel CAD, and based on the guidelines, in patients with non-ST elevation and multivessel disease, the mode of revascularization, either your bypass or your PCI, should be based on the complexity of the vessel and the patient's comorbidities. Now, in stable patients with NSTEMI with multivessel disease but without left main stenosis, who do not want CABG or who are not intended for CABG, PCI of the non-culprit lesion, along with PCI of the culprit lesion, is recommended to reduce the risk of MACE. However, in patients with non-ST elevation MI with multivessel PCI is being considered, we should use physiological assessment of non-culprit stenosis. This is based on your studies such as your FAME trial, where they did find out that using physiology did reduce the incidence of using more stents without an increase in major adverse cardiovascular events. Now, for patients who are unstable, as mentioned earlier by Dr. Ply, patients even with non-ST elevation ACS, routine PCI of non-culprit arteries is harmful to the patient, and we should only do PCI of the culprit lesion if needed. So, how do we choose now between PCI or CABG for patients with NSTEMI and multivessel disease? Now, for patients with NSTEMI, CABG surgery may be preferred over PCI with the following conditions. If you have significant left main coronary stenosis with high complexity, a very high syntax score, multivessel CAD with complex or diffuse vessels, diabetes with multivessel disease, especially with involvement of your left anterior descending artery, or multivessel CAD or complex left main CAD with severe LV dysfunction. Now, in these conditions, CABG is preferred over PCI, but ultimately, it will still depend on patient preference. So, my take-home message for this is that risk stratification for patients with NSTEMI is essential in determining the need for immediate or selective non-invasive approach. Now, for very high risk and high risk patients, they may benefit from an early invasive strategy, while low to intermediate risk patients may be managed with selective invasive strategy with a preference for non-invasive testing first. Now, the choice of either PCI or CABG should depend on the patient profile, the complexity of the vessel, especially for those with multivessel disease. And finally, as always, the decision to do an invasive approach should still be individualized considering the patient's profile, comorbidities, and your patient preference. And always, a heart team approach should be taken so that the treatment goals align with each patient. So with that, I end my slides and thank you for listening.
Thank you, Dr. Santos, for your very up-to-date and very clear logic algorithm for treating patient with non-STE-ACS. I think it is very important concept to categorize patients into the low risk and high risk. And I'm wondering, is there any questions from our experts or the panelists? Okay, please feel free if you want to ask any questions. So, so my question is that it's a very good for the patients to receive the intervention as soon as possible when they need. But my question is that in the routine practice, is like your hospital, it is possible, just like the ST elevation MI, to treat these high-risk patients immediately, especially at the midnight? Or do you have any consensus or about this procedure? Thanks.
Okay, so thank you for that question. Actually, in my practice, at least in the practice of the hospitals where I work in, we do follow the risk stratification for patients with non-ST elevation MI. If the patient is deemed very high risk, meaning they come into the ER who are hemodynamically unstable, then we activate the cath lab immediately. If the patient is a high risk, meaning clinically stable, but a diagnosis of non-ST elevation MI has been established, we do immediate angiography within the 24-hour time frame, and we do follow that as much as possible. And then for patients where we've ruled out very high risk or high risk MI, we do an elective procedure, and we do, at least in my preference, for my practice, for patients who have low or downtrending troponin I or low troponin I, there is a preference for using non-invasive testing first before doing angiography if the need arises. So at least for my practice, we do follow these risk stratification for patients with non-ST elevation MI.
Yes, I also think agree with your practice right now. I think according to the evidence, patients really gains more benefit from the early interventions. And in addition, I think for this kind of patients, unlike the ST elevation MI, the non-STEMI and the non-STE-ACS may have more complex comorbidities. And but when we considering about the high risk ischemic group, but we also should take care about the other comorbidities or even high bleeding risk. So what do you think about that to decide which timing to go?
Yes, actually, at the very least in our practice, if the patient has very high bleeding risk, that's actually a relative contraindication to doing intervention, especially in PCI, especially if we expect to load antiplatelets and give anticoagulants to patient presenting with NSTEMI MI. So we still try to tailor the intervention for the patient if we see, for example, that upon angiography that there is an established flow and we can manage medically, we'll probably manage medically first and then wait until we get clearances, for example, from other services, from urology service or from gastroenterology service, before we proceed with any type of intervention that would require us to give antiplatelet and anticoagulant to the patient. But for example, if the patient is hemodynamically unstable, we do weigh the risk versus the benefit of the bleeding versus the possible mortality of the patient because of his instability from the MI.
Yes, can agree more. I think for this kind of patients, we should have more patient-centered tailoring about management. Okay. And due to the time strain, I think thanks Santos. And I would like to introduce the final speaker from Taiwan and Dr. Yuan Hong Liu, and is currently of the visiting staff and section of cardiology, cardiovascular center, director of animal center from the Far Eastern Memorial Hospital, New Taipei City, Taiwan. Today his talk is about reperfusion strategy and mechanical circulation support in ST elevation MI and non-ST elevation ACS with cardiogenic shock, and focusing on timing and choice. Dr. Liu, please.
Thank you very much, Professor Huang. And I will introduce the revascularization strategy and mechanical circulatory support in ACS with cardiogenic shock. And for the revascularization in ACS with cardiogenic shock, we can see that the shock chart published about 25 years ago, comparing revascularization and medical therapy in the MI patient with cardiogenic shock. And after follow-up at the 30 days, we can see that the mortality from all causes was not different. But however, after following the 6 months, the mortality was lower in the revascularization group than in the medical control group. And we can see that after that, many of the clinical trials comparing the primary endpoint as 30 days later. But some of the significant finding was found in the about 6 months later. I will introduce them later. And for the impact of treatment delay of the mortality in the STEMI patient present with hemodynamic instability, shown here we can see that the more contact tooth balloon time, the more in-hospital mortality, especially in the patient with shock status, with or without OCA. And we can see here, we can see that every 10-minute delay in primary PCI result in 3 to 4 additional deaths in 100 PCI treated patients. And after we can see that after delay for about 6 hours, there are more than 80% mortality rate beyond 6 hours of delay. And we can conclude that primary PCI should be performed in patients with STEMI and cardiogenic shock as soon as possible, ideally within 90 minutes to reduce the mortality rate. And for the PCI perfusion strategy, just probably copied shock chart before, and many speakers has mentioned that before. We can see that to compare the multivessel PCI or the copulation only PCI, the copulation only PCI only may induce the mortality rate by about 16%, and it's mainly to reduce the all-cause mortality in this patient. And also we can also find that there's a reduced rate of the renal replacement therapy. And the cause of the coupling shock, the reason why the coupling only PCI lead to less mortality and less renal replacement therapy may be due to that more contrast may induce the flooding overload in the LV. And also in the patient with unstable hemodynamic status, the more time to do the PCI, the more hazard in this patient. And the revascularization strategy in ACS with cardiogenic shock is that the recommended in CCHA guideline recommend that in patient with ACS or with cardiogenic shock, emergency revascularization of the copulation by PCI or with CABG is indicated to improve survival. And in patient with ACS compared with cardiogenic shock, routine PCI of non-copulation at the time of the primary PCI should not be performed because of the high risk of death and renal failure. And next topic, I will mention the mechanical circulatory support in ACS with cardiogenic shock. And we can see that MI compared with cardiogenic shock, there's high mortality rate about 10%. And the mortality of the cardiogenic shock, the MI with cardiogenic shock is about 40 to 50%. within 30 days, despite of revascularization or mechanical support. And although in patients with cardiogenic shock, mechanical support may improve both systemic and myocardial perfusion, reduce ventricular workload, and provide peri-procedural support for PCI. And the ACLS is increasing use in the treatment of infarct-related cardiogenic shock, despite lack of evidence regarding effect on mortality. And we can see that in the past 25 years, from the shock study published about 25 years ago to IABP shock 2 study to the published shock study, the mortality rate is very similar, about 40 to 50% of the mortality, despite the revascularization and also the mechanical support. And for the mechanical support, the current available temporary mechanical support include VA-ECMO, IPB, Impella, TMR, and IFEC2L. And the VA-ECMO offer the maximal flow about 7 to 10 liters. However, it can offer the LV unloading. And for the IPB, Impella, TMR, and IFEC2L, they offer some part of the LV unloading. But in the previous IABP shock 2 trial, because there is no survival benefit, the ESC and ACHA guideline do not support the routine IABP use in the MI with cardiogenic shock. And for the IABP shock 2 trial, we can see that there is no survival benefit in the IABP group at the 30 days following randomization. And we can see in the MI with cardiogenic shock or the other reason of the cardiogenic shock, the ECLS, the use of ECMO is increasing over the time. And the important paper just published 2 years ago is the ECLS shock trial. And the hypothesis is that early routine ECLS treatment compared with the usual medical therapy may improve the survival with MI complicated with cardiogenic shock. And this is the primary endpoint, the 30-day all-cause mortality. And we can see the inclusion criteria is the MI, whether STEMI or non-STEMI plus planned revascularization or the artery lactate over 3 millimolar. And the exclusion criteria include the revascularization over 45 minutes and onset of shock more than 12 hours. We can see at the 30 days following randomization, there is no survival benefit in the ECLS group. And also we can see there's more severe bleeding and peripheral ischemic complication requiring surgical interventional therapy. And also there is other clinical trial, the ECMO CS trial. There is also no survival benefit. However, it's not the ECMO CS trial is not the MI trial. And the conclusion of the ACS shock trial is that the inpatient with MI and cardiogenic shock, the ECLS do not reduce the 30-day all-cause mortality. And also ECLS is associated with high rate of moderate to severe bleeding and peripheral ischemic complication. However, there are some problems of the ECLS shock trial because there is the higher rate of the mechanical support in the control group, and there is high rate of the crossover rate. We can see that in the control group the crossover rate is high, and also in the control group there is high mechanical support. So about 1/4 of the control group receiving the mechanical support, and also in the ECLS group there are very limited ratio of the patient receiving the LV unloading. So what about the LV unloading? Because the VA-ECMO causes LV overload and it increases the LV afterload owing to the retrograde LT flow. And LV unloading might reduce the PCW wedge pressure and improve pulmonary edema, reduce LA pressure, decrease LV distension, and improve ECMO output and LV ejection fraction, and also improve the ventricular arrhythmia refractory to medical management. The unloading rate is only about 6% is too low, and it's for the ECMO there are some methods to reduce the LV loading, including add on the Impella or other method, and also the most of time we use in Taiwan is the more cheaper the DAFA ECMO. We use the balloon atrial septostomy and insert the ECMO venches into the LA, especially in the LSPV, to reduce the LV pressure. And what's the importance of the timing to active LV unloading during ECMO? We can see here, this is the paper published in the JACC Heart Failure. We can see that the longer the LV, the more delayed the active LV unloading, the higher hazard ratio. And we can see that the LV unloading after 2 hours after VA-ECMO, it leads to the 36% lower relative risk of 30-day mortality, and there's no increased likelihood of complication. And we can see the gradually increasing mortality rate with every hour delay of active LV unloading. And this paper have some problems. The first one is I just mentioned before, there are 1/3 of the control receive mechanical circulatory support. And the MR cardiogenic shock do not mean ECMO only, because we should consider the phenotype of cardiogenic shock. Well, the patient need LV unloading. So at present, some evidence suggest that active LV unloading should be considered with ECMO. Earlier is better. And one important paper just published this year, the dengue shock trial, as the microaxial pump, the Impella, in the AMI-related cardiogenic shock, and includes the STEMI with cardiogenic shock, use the Impella CP. And we can see here the incidence of death at 6 months after randomization, we reduce the mortality with the hazard ratio about 0.74. We can see there is a trend of the favor in the Impella group. And however, we can see overall the primary endpoint is the death from any cause at 6 months. We can see the survival benefit. However, we can see that the adverse effect include the severe bleeding and limb ischemia, and also the number of the need of the renal replace therapy is much higher in the Impella treatment group. And the conclusion of this is the routine use of microaxial flow pump Impella may reduce the death from at 6 months after standard of care. It reduced with the hazard ratio about 0.74, and the number need to treat is about 8. And this is the first treatment strategy to show benefit in patients with AMI with cardiogenic shock since shock trial. And the shock trial is published 25 years ago. And the Impella increased however, the Impella increased the incidence of major bleeding, limb ischemia, and renal replacement. So the patient selection and the timing remain important. However, there are some problems in this trial because it took long period, 10 years, to enroll only 360 patients in the trial, and it may reflect that there may be no study evidence base to justify its use. So it takes so many times because the study started in 2013, but in only one country. However, after 6 years, it enrolled very limited patients, and then it include the patient from the Germany and UK. And this trial, another important issue is that the dengue shock trial included patient had a greater chance at neurologic recovery, and then they may be more likely to benefit from mechanical support. This trial excludes the patient with the Glasgow coma score called less than 8 after OCA, and it much different. In this trial, the resuscitation patient is only about 20%. However, in the ECLS trial and IPE shock 2 trial, the resuscitation patient is about 40%. And also, the trial used the death from any cause at 180 days at the primary endpoint. And other trial like IPE shock 2 and ECLS shock trial, the primary endpoint is to analyze the death from any cause at 30 days. It's different. And we can see that there may be a trend favor the ECLS at the 30 days, but there's no significant difference. So maybe doing this kind of clinical trial, the analysis should be extended to about 6 months. And because due to the protocol, the preferred timing of the placement of Impella is unclear. So the mechanical support in ACS with cardiogenic shock, the ACS guideline subject in select patient is the non-comatose patient with STEMI of severe refractory cardiogenic shock. Insertion of microaxial intravascular flow pump is reasonable to reduce death. In the patient with mechanical complication of acute coronary syndrome, short-term mechanical support devices are reasonable for hemodialysis stable in a bridge to surgery. And the most important is that this no benefit in patients with MI and cardiogenic shock. The routine use of IBP or ECMO is not recommended due to lack of survival benefit. And this is my take-home message. In the patient with acute coronary syndrome complicated by cardiogenic shock, routine PCI of a non-infarct artery at the time of primary PCI should not be performed because of the high risk of death and renal failure. And use of the microaxial flow pump, that is Impella, is reasonable to reduce mortality in patients with STEMI and cardiogenic shock, especially in the patient with the scale shock status CDE and who are non-comatose. Maybe this is the most important. The coma scale should be higher. And at present, study do not support routine use of IBP and VA-ECMO in patients with MI and cardiogenic shock. Thank you very much for your attention.
Okay, thank you, Dr. Liu, for your very comprehensive study presentation about the patients with myocardial infarction and shock. I think this is a very complicated scenario we encounter. Every doctor, I think, we don't want to encounter such that situation. But when we face that the situation, the most important of all is to stabilize the hemodynamic status. Is the first critical thing to do. So probably in addition to the inotropics, the vasopressors, sometimes the mechanical support system can be used. But according to the current scenario situations, we have the IBP, we have the ECMO. Although I know that's probably in some of the countries in Europe, like Germany, they said that after the guidelines and the evidence, they abandoned the IBP at all. I'm not so sure about the other countries. And we have IBP, we have ECMO, and currently we have IVAC2 and Impella. So, but in Taiwan, the most common critics about the ECMO is the increased the LV the afterload. So we recently performed the septostomy, the LABA ECMO to overcome these problems. So, but still lack of evidence. So what do you think about, even though the current guidelines, the HA guidelines, they did recommend least as case 3 indications for the ECMO and IBP. What about your suggestion about that?
Yes, I think, but I think in our experience, some people with MI with cardiogenic shock do benefit from the ECMO because some of them have the refractory VT of VF with cardiogenic shock. And if we use the standard ACLS, the patient cannot return to the sinus reason and cannot have the stable hemodynamic. But once the ECMO is inserted, the refractory VT VF subside, and the patient have the stable hemodynamic and have the chance to recover and have the chance to have the full neurology recovered. So I think maybe the choice of the patient and the timing is important. So because just I mentioned before, maybe because the cardiogenic shock patient is not only the cardiogenic shock, it may be some of the end organ hypoperfusion, and also it has the LV pressure overload. So maybe the add-on LV unloading in a patient with high LV and diastolic pressure, or also in the patient with refractory lung edema or refractory VTF, I think ECMO may be beneficial for this kind of the patient. So, and also I think maybe another important issue is in the MI patient with cardiogenic shock, because the dengue shock chart offers that the people with the non-comatose patient have the more favorable outcome. Maybe I think we should analyze this kind of the ECLS with the ECMO in the non-comatose patient. Maybe this kind of group patient have the more survival benefit, because at present family will request of withdrawal in the patient with unconsciousness. Therefore, so we do not see the survival benefit in this kind of patient, even maybe because the withdrawal of this unconsciousness patient. So maybe if we enroll the patient with the non-comatose patient, maybe the ECMO will be of survival benefit. And also we should observe more longer time, for example, 6 months. Maybe we can see the survival benefit in this kind of patient.
Yes, I think that for ECMO, I think it is probably like we cannot say that it's fit for all the kind of patients. We have certain patients to benefit solely from the ECMO only, like the Dr. Liu said about VTVF refractory one in the AMI settings, and without mechanical support, I think most of the doctors will give up this case in the ER without doing anything. But with the ECMO support, probably it makes us possible to move the patient to the cath lab and open the vessels and do the DC shock and to get it recovered. So I think this is highly recommended in very kinds of guidelines, I think. So what about Santos? Do you have any suggestions? Yeah.
Yes. So I actually would like to get your opinions about this. Not a lot of countries right now do have ready access to the ECMO, and not a lot of people have access to your microaxial flow pump. I know here in the Philippines we don't have that yet. So I know that there are a lot more countries, a lot more cath labs, hospitals that have ready access to your intra-aortic balloon pump. And even though it does not support the routine use of IABP, would you personally still use IABP if that was the only thing available as part of hemodynamic support for patients with cardiogenic shock who present to your hospitals?
At present, because of the guideline do not suggest the routine IABP use in the cardiogenic shock, so I do not routine use the IABP. But in the patient with high risk intervention, for example, the left main disease, in the left main disease with or without ACS condition, I will use IABP support to facilitate the procedure. I think the role of IABP maybe play the role in the high risk intervention.
Okay.
Yes, as for me, I think the IBP I still use it for sometimes, since that it is, although we have ECMO team in our hospital, but it is not really that quick for them to get ready. So probably in addition to the inotropes, we still have some support in advance. So in practice, I would install the IBP first. And the other thing is that the ECMO itself is increased the afterload, but when combined with the IBP use, it can relieve some of the tension. So, yes. And from previous clinical trials, for the trial that benefit from ECMO also have IBP. I think we will do it simultaneously sometimes. Yeah.
Okay,
Thanks.
that's good.
Okay, and is there any questions from the floor? Any? Okay, if not, I think thank you, Dr. Liu. And due to the time strain, I'm glad to have Dr. Santos to have the closing remark.
All right. So thank you, Dr. Huang. I believe that we've had a wonderful and very educational session today. We've seen that with every new guideline release, every new study that's been published, the landscape of the management of STEMI and STEMI, especially with the new and emerging technologies, as well as evidence-based indications for our daily use and practice, I can only see that we can become better in successfully treating patients with acute coronary syndrome. So I would like to thank everyone who joined us today. Thank you to our program director, Dr. June Lee Lin, to my co-chairman, Dr. Huang, and to our esteemed speakers, Dr. Isman Firdao, Dr. Namkai Chirengombo, Dr. Plai Chicharion, and Dr. Yuan Hong Liu. And thank you to the APSC Cloud Forum on Cardiovascular Disease for giving us this opportunity to present today. So thank you, everyone, and have a great day ahead.
Thank you.
Thank you. Bye.
Thank you. Goodbye.